Okay, well, hi everyone, and welcome to the NCCN Best Practices webinar series about creative strategies developed during the COVID-19 pandemic that will impact the future of cancer care. My name is Gina Szymanski, and I'm the Director of Process and Program Management at NCCN. In this third and final session of the series, we will be discussing modifications in cancer treatment and delivery. NCCN would like to thank these organizations for supporting the webinar series. We greatly appreciate their contributions, and without them, this program would not be possible. So thank you very much. I would now like to introduce our speakers for today. Our first presentation will be presented by Gina Szymanski and MiKaela Olsen from the Sidney Kimmel Comprehensive Cancer Center. Gina has been an oncology nurse for 38 years at the Johns Hopkins Cancer Center. She began her first 10 years of service at the bedside caring for solid tumor and BMT patients. Gina has also managed inpatient services, co-founded an outpatient transplant program called the IPOP Clinic, and opened Johns Hopkins' first inpatient hematology unit for non-malignant patients. In 2014, Gina assumed management responsibility for all medical oncology ambulatory services, and she is currently the interim director of nursing for the Cancer Center. MiKaela Olsen is an oncology and hematology clinical nurse specialist who oversees clinical operations for ambulatory oncology services. She serves as adjunct faculty for the Johns Hopkins School of Nursing and faculty associate at the University of Maryland School of Nursing. MiKaela is a certified advanced oncology clinical nurse specialist and holds a Doctor of Nursing practice degree from the University of Maryland. We will also hear from Dr. Lawrence Shulman from the Abramson Cancer Center. Dr. Shulman is Professor of Medicine at the University of Pennsylvania, Deputy Director for Clinical Services of the Abramson Cancer Center, and Director of the Center for Global Cancer Medicine. He is a specialist in the treatment of patients with breast cancer, and his research includes development of new cancer therapies and implementation of cancer treatment programs in low-resource settings. Dr. Shulman is also currently chair of the Commission on Cancer and is a member of the NCCN Best Practices Committee. Additionally, he has led the World Health Organization's review and revision of their essential medicines for cancer. We would like to thank all of our speakers for joining us today. Before we get started, I want to remind everyone that if you have any questions during today's presentation, please feel free to submit your questions through the Q&A box located on your screen. We should have time to address questions towards the end of the webinar. And now I will hand it over to Gina and MiKaela for our first presentation.
Thanks so much, Jessica and Mark, for inviting us today to participate in this discussion about COVID and care adaptations that have occurred as a result of this pandemic. I'm going to start with some background and get into sort of our first sort of adaptation that we felt like was a really important give to our patients, and then MiKaela will pick up with the remainder. To adapt, the act or process of making something fit. That's according to Webster. And our job for the past 90+ days has been about making sense of what's been happening around us and to figure out how to make it all fit, into our current model of care delivery, a new model of care delivery or not. But the goal is really about the fit. One of the most important things that we've learned from our experience is that patients made choices to stay outside of the hospital and receive care in more innovative and patient-centered ways. They isolated at home and chose environmental measures like social distancing and masking to maximize their health. Patients valued the convenience of not coming into buildings where they're at higher risk for exposure, but instead participated in video visits. They liked not having to park or pay for parking. They liked staying in their cars to receive care. This is the seed that's been planted to shape the next generation of oncology care. I think we're at a really pivotal point where a lot of what we've learned and what we're doing, all these adaptations that we're making, are really seeds that are likely to generate something very different going forward. This is just a snapshot. These are staffed beds when you look at these pictures here. We thought we'd start by sharing some of the data from Maryland just to give you some context of what we've been dealing with. As the pandemic was named, we had already been learning and watching this virus from watching the experiences in Europe, Washington State, and New York City. Our governor acknowledged the pandemic in Maryland on March 5th and declared a state of emergency. And on March 30th, he announced the stay-at-home directive to really stop the spread of this virus. And I think, truth be told, I think we feel very, very fortunate here in the state of Maryland, specifically our health system, but really the whole state. We had a governor that really jumped on things very early. And while the curve of acute care looks pretty dramatic, it kind of looks like a spike. We really didn't feel a lot of this as a spike. It was just sort of this ramp up, and then we were on board and just kind of riding the wave. So it really was an environment that we felt that we were, for the most part, able to control. As you can see from the graph on the right, the green bars, available staffed beds. We did not run out of beds. We did not run out of ventilators. We did not run out of supplies or PPE. We really were able to stay on top of this, much of this, again, because of previous knowledge and learning from others. This is an EPIC dashboard actually developed at Hopkins. This is another really an early adaptation, this recognition that we needed data to really help us understand what we were seeing. This is a snapshot in time. One of these dashboards generates every day at Hopkins, and it's actually for our entire health system has access and participates in this dashboard. So this really shows, this is one of three sort of rows of tiles that show up. It's a lot of data. But we can follow the number of cases, the mortality rate, patients on vents and on high flow oxygen, PUIs, deaths, and all kinds of really very interesting data. We can see it for each one of our affiliates so that we understand what's happening with all our affiliates. This was very much an affiliate effort, us getting into this game and really being able to manage so well. And we really appreciate having the data to be able to see what's happening amongst all of us. We knew from watching the experience of others that our beds would remain full and ongoing capacity would be an issue. Pre-COVID, our average occupancy were in like 95% all the time. We never had a lot of available beds. We didn't live that way. We knew there would be overwhelming pressure on our workforce, that overnight stretch in their skill set that needed to occur, and the stress and the emotional burden associated with the unknown. We knew that would be really problematic. We knew we would have to create our own path for how COVID and non-COVID patients would coexist in our spaces. We knew oncology patients from the beginning of time, and for me, 38 years is a long time, really have always been educated about the principles of infection prevention and self-care. They've been educated about masking and distancing and hand hygiene and self-isolating as part of managing their disease. They just know these things. Staff have had the benefit, like I said, of learning from those that went before us, and there was a lot of attention paid to folks that were struggling well before it really hit in Maryland. Patients benefited from watching others, and really what they chose to do, at least our experience at Hopkins, was to shelter at home. Staff and patients had time really to prepare for the worst. Our cancer center remained very committed to our values of 24-hour access for our patients, keeping patients out of the hospital and the ED, treating them on time if delaying their treatment was not an option. So really, this benefit of knowing really helped in the adaptive process for us. This kind of lists what we really see as sort of adaptive moments and things that we really invested in to kind of keep things moving and stay on top of the care that we needed to deliver. They really centered on, unique staffing models across the house, very unique staffing models in terms of being able to deploy nurses from one part of the hospital to another. This was real-time deployment that happened every 12 hours. Nurses were asked to upskill in real time, get some additional training to help cover IMC and ICU needs by becoming nurse extenders. So the unique staffing models, a real-time structural change to our environments, which I'm sure everybody experiencing, really being able to convert to negative pressure and then manage the beds that we actually converted. We did a lot with screening and access, putting nurses at our front doors in our cancer centers and our buildings. Visitor restrictions was a very big commitment on our part. We managed our own PUIs to ensure clarity regarding treatment side effects versus COVID symptoms, and that was very important to us to be able to do that on the PUI side. And then the testing and treating COVID positive patients. This is the first adaptation that we're going to speak to. Our hospital is really very committed, continues to be very committed to separating COVID and non-COVID patients. So we actually talk about this bimodal world that we're in, that we will likely be in for the foreseeable future. Our cancer center buildings, which include surgical, medical, and radiation oncology, both inpatient and outpatient services, are all non-COVID buildings. As we began to work on sort of these adaptations and the new COVID world, alternate treatment sites became a very big point of discussion for us. Again, we mentioned this briefly, but we are part of the Johns Hopkins Hospital is a health system. There are 6 hospitals in that health system, 4 of them in the state of Maryland, Sibley Memorial, which is in DC, and All Children's, which is in Florida. All planning, all action, all workflows, all algorithms, everything was shared amongst the affiliates. And while we weren't rubber stamping sort of one size fits all, we certainly were creating together and wanting to make sure we shared what we learned. All decisions and solutions, like I said, always benefited the health system, and we'll talk a little bit more about that when we get into our adaptations we're going to share. This is a picture that we show a lot just to kind of describe the depth and breadth of sort of what we touch in the cancer world. And it's really a pictorial of our commitment to prepare to see our patients, a lot of this work is really ambulatory based because we make a huge commitment to see them in the ambulatory environment as a first priority and create alternative workflows and care environments for patients who require care in between their visits. And we have lots of programs and services up in the right-hand corner that actually support this commitment to prepare to see ambulatory patients and really know what their status is at all times, especially right before they come in for treatment. Urgent care is really about between those scheduled appointments, what do we do if we have a problem, really focusing on not sending them to the ED and not necessarily admitting them. We've got an urgent care clinic that we have actually added to. So lots of programs and services that help us ensure that they're really ready to be seen and brought in for treatment. Because of these services and this, the 48-hour rule of preparing in advance, calling them the night before and doing really very treatment and drug-based assessments to be sure that they're not having any symptoms where we might want to see a provider before we treat them. Because of these systems and programs that we had in place, we were actually very well positioned to take on COVID screening, which we actually did. All patients that were seen the next day got a call because of their drugs and wanting to look at any problems they were having related to their therapy, but we also did COVID screening that night before, as well as screening them at the front door the next morning. So we were set up from the beginning with some of these programs that I think were very important to our success. This really shows the footprint, and I don't want to spend a lot of time on this, but this is the footprint at Hopkins, and basically it shows the COVID and non-COVID ICUs, IMCs, and acute care beds, and then labor delivery kind of came on. If you look across the bottom, what we started out with was a lot of non-COVID acute care beds that kind of dropped off as we needed more COVID positive patient beds. And then kind of once we invested in the COVID positive in these acute care beds, you can see that, they went up and kind of came back down. But a lot of this is about moving beds from IMC or critical care status, COVID, non-COVID. We were switching all the time depending on what the need was. And we were able to keep pretty good track of this and make sense of sort of what was happening. But the front end was very much about, COVID ICU care and all those patients that we were having to see and treat. But once we got a handle on that and those COVID positive patients started to drop off, then the non-COVID beds became what we really needed to focus on. So we were able to stay in that game fairly well. The footprint in our cancer buildings. So the top building is the Sidney Kimmel Center. That's got all three treatment modalities under it, including inpatient services as well as outpatient. The building at the bottom is our newest building. It's 2 years old. It's the Viragh building. And so between those two buildings, there are about 60 infusion chairs that make up those two buildings. And like I said, in the top building, when you read to the right, some of the inpatient stuff, all of our inpatient care is in the Kimmel Comprehensive Cancer Center at the top. So we have 7 inpatient negative pressure rooms between these two buildings. Those 7 rooms are on the inpatient unit. There are not 79 non-COVID inpatient beds. Both of our buildings were COVID negative buildings. 11 chairs and stretchers in our urgent care biocontainment unit, which we'll tell you about. That makes us not 100% non-COVID, but pretty close. We have about 94 infusion chairs between these two buildings that take care of basically three outpatient clinics. Oops, I didn't put in my number. There's a total of 37 plus another 10, I think, about 47 provider clinic exam rooms. I was cleaning up that number yesterday between these two buildings. So these are provider clinics where we see patients 5 days a week. Radiation and therapy does have one linear accelerator that is positive. It is used to treat positive patients. And at the end of the day, up until about June 4th, we had seen about 261 PUIs in our inpatient units, 5 of which were positive and admitted to the main hospital into a biocontainment unit in the main house. So while we have worked really hard to be able to manage and take care of COVID positive oncology patients and be able to treat them and meet their needs, there just hasn't been as many as we initially expected, which has actually been a good thing. This is our first innovative adaptation. We stood up an urgent care clinic, a bioclinic, quickly, probably in less than 3 weeks, doing some modest renovations in a radiology space that basically closed down 2 years ago, and it's adjacent to our original urgent care clinic. This space it's 5 large rooms, basically, that these people are standing in front of, and within those rooms, we put up path walls and curtains and created 11 treatment spots. It's all negative pressure. We were able to switch this entire suite to all negative pressure with HEPA filters, and it does have its own donning and doffing room that we were able to attach. We did build an ante-room to the front door so that it truly is a negative safe place. What you see in the hallway is staffed with 2 nurses and 2 clin techs and 2 patient safety officers, transport officers. These folks are in the space all day, even while the numbers were very, very low. There were days we saw as many as 6 patients and days where we saw 1. But these folks were all available to be able to provide that support. Really, the upper left-hand corner is sort of the newest addition to our urgent care mission statement. We've always, in our urgent care settings, looked to reduce ED visits, prevent admissions, decompress inpatient beds when needed, and now this new commitment that will be with us for a while to treat positive patients, to rule out and treat positive patients, either related to treatment toxicities or those who actually need their cancer treatment. We're committed to do both. This is a picture of our urgent care space. I don't know if the mouse will work. It looks like it on my end. This is the front door that patients come through. This is the door that staff come through. Donning and doffing is actually in the same room. This room is divided in half this way, if you will. So you come in sort of on, against a counter with some cabinets where you can do drop-off of meds and different things for folks who can't come all the way in. But you come out of this door and doff in this front area and donning below. To the right here, so as a patient coming through this front door, and all these patients are supervised. They are told to park and meet us at our ambulance entrance to our building. and a patient safety officer and a nurse and a security guard will go down and meet them, bring them up on a specific set of elevators on a specific route, and they will travel through this front door. So again, an ante-room to the actual space. This is the hallway where everybody was standing, and then there are these rooms that flag around this way. Again, all negative space. We actually have 2 restrooms here. We were able to easily add a second restroom. One was for COVID positive patients, and the other was for PUIs, who we assumed in some ways to be positive in this scenario. We assumed them to be negative because we didn't want them to necessarily mix with known positives. Part of the role with those safety officers, they walked patients to the bathroom, stayed right outside of the bathroom with them, and then the ClinTech was there when they came out to completely wipe down the bathroom when they were done. Our respite room was through, actually the way to get to the respite room is they would come out of doffing, walk down the hall, and come in the front door over here. This was actually radiology waiting, and this is the radiology space. So we clipped that out of the universe and made ourselves an urgent care 2 biospace. This is just showing the pathway for donning and doffing. People were always surprised that we did this in one room, but you actually can do that safely if you set it up correctly. And this is our count so far in this visit volume from April 15th when we opened to June 6th. About 115 patients came through that biospace, averaging about 3 a day, Monday through Friday, and sometimes 1 to 2 on the weekends. We have since made adjustments in our staffing, and our staffing now with, actually, we had a provider that was floating down from our clinics, different providers each day, and these were folks that were on usually administrative days in the clinic. These were fellows and attendings and whoever volunteered to kind of be on the schedule. So we clipped them out at the front end, and the urgent care, our original urgent care space, which is really right next door to this, there's an NP provider in there. And because these volumes were low, we've been trying the last couple of weeks to try and manage with our 1 NP who moves between these 2 spaces, but we also have a backup provider on call. Switch the hours of this clinic. We're 10-hour business days instead of 12. Now we overlap our ClinTechs for a couple of hours, but usually there's about 1 ClinTech there for most of the day. Our nurses put in 2 nurses a full 10-hour day. But we did reduce the hours. We cut out Saturdays to try and deal with the low volume. And now I'm going to turn it over to MiKaela, where she will pick up with our next 2 adaptations.
I think the main goal of setting up that urgent care biospace and those negative pressure rooms where Gina showed that we took care of over 280 patients was to really maintain our cancer patients in our space as much as possible during this COVID pandemic. So keep them out of the ED, keep them out of main hospital beds unless they were COVID positive. And we really successfully did that by setting up these spaces and teaching our own staff how to properly don and doff PPE and setting up our own safety officer and transport safety officer program. So what we did next, and this actually just got approved last week, was we developed a pathway. So now that we're going to be living with possibly for quite some time with a mixture of COVID and non-COVID oncology patients, how do we care for our COVID positive patients? We had some examples. We had a young patient with breast cancer whose cancer was progressing and she continued to need her chemotherapy despite being positive, so we were able to treat her. So there are different pathways for patients coming into our urgent care biospace. One would be that they're positive and they have some acute need that would normally have gone to our regular urgent care. So they would obviously come into urgent care bio. The next scenario would be that they have an active beacon treatment plan or an active beacon therapy plan that requires them to receive some kind of therapy, either their therapy for their cancer or supportive care therapy such as blood hydration, shots, pain control, etc. Rather than these patients going into the ED or being afraid to come in because they're COVID positive or being allowed to be cared for in our setting, we stood up this biourgent care program for these patients. And as Gina said, we will continue to keep this program going as long as it's necessary. We also still need to do bone marrow biopsies or other procedures on COVID positive patients. So the pathway was developed to help us be able to care for these patients within the cancer center and with our own staff that the patients are used to. And this has been a great patient satisfier. Patients were already very scared and unsure of the new environment, and knowing that they had a space to come to if they got sick and they would be taken care of by the nurses and the providers that they're used to was very comforting to them. And then we have a pathway for re-entry into regular care after their negative testing is done. So just real quick about our curbside clinics, and then we're almost done, and we'll turn it over to Larry. The Viragh Curbside Clinic that's our solid tumor building. Got up and running very early on in the pandemic, and it was easy for us to do because we already have shot clinics. So we had already taken all of our injections out of our infusion space. We had designated staff for those patients. We had 15-minute fast track appointments already. So the patients were already used to the injection clinic, but they had to come into the building. They had to pay for parking. When we started to hear examples of patients that were afraid to come to get their hormone shots, afraid to enter the building, and were delaying care because they didn't want to come, we decided we needed to figure out a creative approach so that those patients wouldn't have to come into the building. We decided to take our entire program and just literally move it down to the curb, got approval through the various people that we needed to do that with and our law office, and called patients. We already use our ACE program that Gina mentioned to clear these patients in advance and do a night before phone assessment, a night before COVID screen. So it was pretty easy to just then educate the patients that we're going to be doing your shot from your car, your blood draw from your car, your dressing change, your VAD flush, whatever it is that you needed for that appointment would be done at the curbside. And I honestly, between the two clinics, we've treated over 500 patients as of yesterday, and I haven't heard a single complaint from any patients. They've just really enjoyed this flexibility and the efficiency of it, really. So that clinic, we do a lot of hormone shots. We do a lot of growth factors and some bone reforming shots and other things. We also are a saline-only flush cancer center, so patients will come to get their port flushes or other catheter flushes in our curbside clinic with saline. So these are the numbers up to June 4th. So we're averaging between 14, 15, and 17 shots a day. So the nurse stays pretty busy in that injection clinic and really enjoys it. We do have contingency plans for weather problems where we can bring them into our parking garage. And then this is the Weinberg Curbside Clinic. The difference between this clinic and the other clinic is this is the heme malignancy clinic. And so in this clinic, we actually decided to get bold and think about some of our sub-Q chemo injections that we do. So we do Velcade shots here, very patient-centered. We're getting ready to roll out some azacitidine injections and possibly some other chemotherapy injections as our clinic grows. We do a lot of immunizations post-transplant, growth factors, and again, central line care and blood draws. And lots of success in this clinic as well. And these are heme nurses that man the clinic so the patients are familiar with them. They do all the teaching and all of the pre-assessment as well. So in summary, we're working on next steps. We're trying to create a picture of the new way. What is the future of cancer care? And I know from standing up some of these innovations that we are hopeful that we can continue them, and I know our patients hope that we can continue them. We were worried about patient volumes increasing as well. We want them to increase, but we're worried about how to continue to physically distance, visitation policy, all the staff that will be returning to work, and the opening of our cancer research program. So many of these programs need to continue, and we need to think about how we're going to provide care going forward, and hopefully keep these things going for our patients. Thank you.
Thank you, Gina and MiKaela. That was fantastic. Really great information about how you developed the new urgent care clinic and the Curbside clinic. Very innovative. Thank you for sharing. I did see a couple questions come in, so we will try to address those at the end. But members of our audience should feel free to continue to submit questions. And we will now hear from Dr. Shulman from the Abramson Cancer Center. Dr. Shulman?
Thank you, Jessica, and thank you everyone for having me this afternoon. So my talk, I think, will dovetail nicely with Gina and MiKaela and their talk. And what I would like to think about with you is just to think about where we are now and where we want to go. And I think one of the rules of life, if you will, is that things that are truly disruptive, and certainly this pandemic has been incredibly disruptive, things that are truly disruptive also allow you to change things that previously were difficult to change. And one of the things that I challenge my faculty with frequently is, why do we do what we do? And their answer would be, it's based on the latest and the best data, but I would suggest it's like Fiddler on the Roof. We do a lot of things because that's the way we always did them. We do them because of tradition, and we have been forced with the pandemic to rethink things that we've considered to be just standard of care for a very long time. I think that's actually been a good exercise for us, if you will. The COVID pandemic has forced us to think about patient care differently. I think previously we thought about just what the needs of the patient were, what type of cancer they had, what the treatment options were, balancing benefits and risks of that treatment, and the needs and desires of the patient, period. And suddenly we had other factors to take into consideration, including what the infection risk was to the patient, to the staff, the patient might be exposing to, and what the hospital resources were, as Gina and MiKaela pointed out, testing capacity, ICU capacity, surgery capacity, and so on. So suddenly, our way of operating and just focusing on the patient was very, very different. We were forced to reconsider lots of different treatment paradigms. At Penn, our interventional pulmonologists who frequently did the initial lung cancer biopsies and diagnostics were redeployed to staff COVID ICUs very, very quickly. Mammographers were redeployed to chest radiology. Surgery volumes were rapidly reduced. And so those almost instantly made us think about doing things differently. Now, one of the ways that I've found it helpful is to think about what processes we were forced to do differently versus what treatment were we forced to do differently. So telemedicine might be a process. We're still providing or trying to provide the same type of care, the same goals, and so on, but some of the care was delivered in a different process, if you will. We'll talk a little bit about treatment at home. The patients are getting the same treatment they would have gotten in the hospital and the infusion unit, just in a different setting. And we'll talk a little bit about palliative care as well. On the other hand, there are some treatments that we've done really quite differently. And we'll talk a little bit about those as well. So those are really decisions about not how we're providing the care, but what care we are providing. I wanted to start with this. This came out in early March from Cancer Care Ontario about how we should think about prioritizing care. And this was when the pandemic was starting to get going, both here and in Canada. And what they did was they categorized care in three priority levels, priority A, B, and C, where A was something that needed to be taken care of right away. It could be neutropenia and fever, it could be spinal cord compression or symptomatic brain metastases, but those treatments could not wait and needed to be taken care of in some way, often similar to what we were doing or the same as what we were doing before. And priority B were patients who required services in cancer centers, hospitals, or primary care settings, but whose situation was non-critical, and there could be some degree of delay or restructuring of their care. And priority C were generally healthy patients whose condition was not life-threatening, where service could be delayed significantly without affecting outcomes. And ductal carcinoma in situ for breast cancer might be a good example. You can't delay it forever, but certainly delaying it for several months, unlikely to change the outcome. And what we did as a nation and individual institutions is we quickly got together and used these categories to prioritize how we were going to deliver care. And this was an example of a number of organizations which traditionally didn't work all that closely together: the NAPBC, COC, the American Society of Breast Surgeons, the American College of Radiology, and NCCN. And we got a bunch of us together, listed here, and in literally a week's time, wrote out priorities for all aspects of breast cancer care and published it. And you can see at the bottom left, this was received by a journal on April 8th and accepted 2 days later and published online several days after that. This was an incredibly rapid process. Likewise, at Penn, what we did was we pulled together what we called COVID urgent teams by disease group, and our thoracic group, like all of our other disease groups, came together rapidly, including surgeons and medical oncologists, radiation oncologists, pathologists, radiologists, social workers, navigators, and so on. And they basically rewrote all of our pathways. We have extensive pathways at Penn, but they were pre-COVID pathways. They rewrote the pathways. They actually documented it all in this manuscript, which was rapidly published by JCO Oncology Practice, again, within a week or so of its conception. So that got us going in the right direction. But what about going forward? And we're now starting to think, well, you know, the virus is not going to go away tomorrow. We don't know about second waves. We don't know about what our hospitals and programs will need to do to care for both cancer patients and non-cancer patients. And one of the things that at least we found at Penn, and I think others have found as well, is it's sort of harder to figure out how to reopen than to shut down. When we shut down, we just did it. We did it quickly, and we figured things out sort of day to day. And now we're trying to figure out what we should do, what we should continue to delay, whether we should do things differently. And part of that's the uncertainty of the COVID infection course, and none of us can really predict what that's going to be. But there's some other things that we've struggled with at Penn and others have struggled with. We're thinking a lot about clinic capacity. If you went to our clinics, and I'm sure this is the same for those of you listening, in January, our waiting rooms were full. All the seats were taken. People were standing in the corner shoulder to shoulder, and we're not going to have waiting rooms like that anymore. And we need to figure out how to run volumes in clinics so that the waiting rooms don't look like that. Room cleaning and turnover. You know, in the old days, you know, the medical assistant walked in, put a new sheet on the exam table, and walked out. And now things are getting scrubbed down, and there's relatively thorough cleaning between each patient. And we're also trying to keep the staff non-congested, if that's such a word. That, you know, we used to have provider workrooms where people were crowded in with each other, and now we're trying to limit 1 to 2 providers per provider workroom, similarly with the support staff and so on. So we're trying to figure out at 10, how many patients can we see in person every day? And therefore, how many patients do we need to see on telehealth, and how are we going to staff both of those lanes, if you will, of care? And on top of that, we don't know what reimbursement and the financial health of our programs are going to be. We don't know whether payers are going to continue to pay for telehealth at the same level. We don't know about some of the aspects of care at home, and I'll come back to that in a couple of minutes. So lots of unknowns in all of this. We all believe, I think, that telemedicine is here to stay at some level. We're hoping that the payers will realize what the benefits of telehealth are, and there are a lot of benefits. I'll talk about a few of them. The last NCCN webinar that occurred last week was focused on telemedicine, so I'm not going to go into that in detail. But we have had different approaches to palliative care and end-of-life care, surveillance, and survivorship and long-term care. And I'll talk a little bit about each one of those, care at home and elimination of low-value care. So what about treatment at home? So I made up this slide. It's totally fabricated, but I think it's actually probably relatively true. You know, what happens when somebody with prostate cancer or breast cancer needs to come in for a Lupron injection? Any of you who have been to Philadelphia driving in the Schuylkill Expressway and trying to get to Penn, a 1-hour drive in is probably not atypical. 30 minutes to park. I can't tell you how many times patients have come into the clinic sweaty, and I've asked them what happened. They said they were 3 blocks away in gridlock traffic, and they got out of their car. Their son drove the rest of the way, and they jogged to clinic. They wait for 45 minutes till they can be seen by a nurse. They get their injection in a few minutes. They need to pick their car up, and they need to drive home. And, you know, in this scenario, it takes nearly 4 hours. And again, I don't think this is atypical. If a patient's at home, the nurse shows up, gets a little bit of history, make sure the patient's okay, gives them the injection, and they're in and out in 20 minutes. And the patient can go on with their activities. So this is actually what's happened at Penn. This was run by the Penn Center for Cancer Care Innovation at the Abramson Cancer Center. That's led by Justin Beckelman, one of our radiation oncologists. And you can see at the left side of the screen the numbers in February. That was before the pandemic. And this started out as a neat little research project to figure out the mechanics of doing this and whether it would work and be accepted by providers and patients. And then you can see that in mid-March, the pandemic was suddenly upon us, and we turned around to the group and we said that this can't any longer be a small research project. We need to operationalize this. And so this reflects the number of patients who have been referred for home administration. A lot of these are Lupron, but an increasing number of them are things like rituximab or pembrolizumab, and the patients frankly love it. We are doing some formal assessments of patient satisfaction and provider satisfaction, but I can tell you anecdotally, the patients, you know, just think this is the best thing. And I can understand why if you tried to get to our clinics during the day. Palliative care and end-of-life care. Well, you know, who are these people? And we know that some palliative care is delivered to relatively healthy patients on curative therapy for nausea management or whatever, but a lot of palliative care is linked with end-of-life care. And these are our sickest patients. And they're the patients who are most burdened by coming to the clinic or coming to the hospital. It's hard for them to get in. Some of them actually end up coming in by ambulance. They often come in with several family members because they can't ambulate well. And this was really tough for them, but we made them do it. And we made a decision early on in the pandemic that we would do the majority, if not all, of our palliative care consultations via telemedicine. And some interesting things happened. First of all, the number of palliative care consultations went up. This was a very acceptable way for patients to get palliative care consultations. And one of our problems prior to the pandemic was that we had a high no-show rate. The patient would see their oncologist on Monday. The oncologist would say, you really need to see one of our palliative care specialists. Why don't you come back on Thursday? And Thursday would come and the patient would say, it's just not worth it for me to schlep in again for this. And the no-show rate greatly decreased with telemedicine. A couple of other things which we've not quantitated well, but anecdotally we think are true. There's been a decline in the use of very late line therapy. I said nth line therapy here to be vague about it, but that's one of the things we struggle about in medicine. And this, I think, is partly the interventions of the palliative care doctors, but partly the patients saying, it's so good to be at home. It's so good not to have to come into the hospital. What are the chances really of that therapy helping me? And us helping them to make a comfortable decision not to go on with therapy. Prior to the pandemic, we had a major program where we had adapted Atul Gawande and Susan Block's Ariadne Labs serious illness conversation, and we had ways to prompt providers to have this to try to align the goals of care of the patient and their family with what was actually being offered to the patient and delivered. And prior to the pandemic, we had done something like 3,000 or 3,500 of these conversations. And they were all done in person, face-to-face, often with the family member. We were concerned that we would do less of these with time, but in fact, the opposite happened, and more of these conversations have occurred. And I think it goes along with the point above about declining fetal therapy near the end of life. And we've also seemed to have had an increase in early hospice use. So this is something that, assuming that we can continue to get paid for telemedicine and continue to support this program, is probably something that's better for the patients. I'm sure there will be times when in-person consultations are better, but frankly, I think this has been a boon for our end-of-life patients. Likewise, for many of our patients who are undergoing surveillance or survivorship or long-term follow-up, we have to ask ourselves, how many times does the prostate cancer patient who's had a total prostatectomy and a PSA of 0 come in, get his PSA, which is again 0, be hugged by his GU medical oncologist, says, look, things look great, you feel well, your PSA is 0, see you next year. Do they really need to come in for that? Do we really need to examine them unless they have particular symptoms or unless their PSA is rising? What about the frequency of surveillance imaging and visits? I think we've done them somewhat less. Patients have been reluctant to come back for imaging if they don't really need to. In some circumstance where we might be doing it every 3 months or 4 months, if the patient's feeling fine, do we really need to do it? There is one study that was run in France by Ethan Bash and collaborators where they actually were able to show in lung cancer patients that just knowing how the patient was doing with patient-reported outcomes led to better care and survival than doing periodic scans. And long-term survivorship, that certainly many of these patients are well. We need to touch base with them once in a while. Occasionally they have to have imaging like a breast cancer patient might, but many times their needs can be met by televisits, and we're likely, I think, to continue those as well. But going forward, what is the right combination? When you look at telemedicine at Penn, it peaked in April and early May. We're still doing a lot of it, though the percentage of visits by telemedicine is somewhat less. So how do we think about treatment decisions? This is a slide that I've actually used in some of my quality talks before the pandemic. but I think rings true here as well. And these are two hypothetical oncologists. Oncologist A says, if the data aren't clear, I would give the chemotherapy with the chance that it might improve survival, would not want to deny the patient that potential benefit. Oncologist B says, if the data are unclear with no proved survival benefit, I would not want to expose the patient to potentially toxic therapy without hard data. And in fact, we have these types of discussions every week at our tumor boards, and we know from some national surveys that different cancer centers approach the same decisions really quite differently. So just a couple of things, and these are examples of things that we've done at Penn, but I know have also been done elsewhere and were reflected, for instance, in that breast cancer prioritization document I showed you earlier on. What about a patient who's got newly diagnosed estrogen receptor positive, HER2 negative breast cancer? Frequently, those patients went right to surgery. Many of them did not go right to surgery because of the pandemic. Some of them also had more advanced disease, and preoperative or neoadjuvant therapy would have been indicated. And in the U.S., that neoadjuvant therapy had been primarily chemotherapy. In Europe, it had been primarily hormonal therapy, and there actually are some data to suggest that in some patients, the hormonal therapy is going to be more active. But it's certainly in the right patient, the right thing to do. And so at Penn and many other places, we're now treating a lot of these patients with neoadjuvant hormonal therapy that we weren't doing before. And at our own tumor boards, people are starting to say, well, geez, maybe this is like a good idea. The Europeans could have been right, and maybe we should continue to do it. Reduction in low-value care. And I've already mentioned reduction in end-of-life care, which we've started, or end-of-life chemotherapy, not care. These patients still get care. But end-of-life chemotherapy, and I think that that's been a good thing. But what about some of the adjuvant trials where we show that a 2% improvement in survival with a much more toxic regimen? Is that really the right decision? What does that really mean? It means that 2% of the patients are benefiting, 98% of the patients are receiving the more toxic therapy without benefit. And I think we need to think about that. And the other similar circumstances, what about the treatment in the advanced stage disease patient that prolongs life 2 months? That could be, for some patients, critical 2 months, and for others, they don't want to be receiving chemotherapy and suffering the toxic side effects of it for the last few months that they have. So we're starting to think about these decisions a little bit differently. In the area of radiation oncology, hypofractionation was starting to become more widely utilized in the U.S., but particularly in the palliative setting and the metastatic setting for bone metastases and similar circumstances. Again, the Europeans were using far fewer fractions than we were in the U.S., but in the U.S. we started using fewer fractions to expose the patient fewer times needing to come into the hospital. And I think the patients and the staff both benefited from that reduction in direct contact. And there's good data to show that that's a reasonable thing to do. A couple of things about patient desires. There, at least at Penn in Philadelphia, there is an ongoing fear for COVID infection. As we work our way through those priority lists that I showed you earlier on, and we're now telling the DCIS patient, all right, to come in and get your surgery and your radiation, they're saying, geez, do I really need to come in now? Can I wait for a few more months and see how the pandemic goes? There is the knowledge among our staff and many of our patients that cancer patients are at greater risk for complications of COVID. That certainly is true for patients who have active disease and are undergoing active therapy, particularly patients with hematologic malignancies and lung cancer. But there's some evidence to suggest that even long-term cancer survivors are at greater risk, and many of them have been reluctant to come in person and really have been quite happy with telemedicine and reducing the frequency of their visits. And then the other thing, I think it was Gina who mentioned this about Hopkins. Many of us, and Penn is one of those places, has a series of owned or affiliated hospitals outside of your urban area. Penn owns 6 hospitals. 3 of them are in downtown Philadelphia, but 3 of them are outside of Philadelphia. And many of our patients have requested to have their therapy moved to one of our suburban centers and to avoid coming in to Philadelphia to the large academic center. We don't have any evidence really that this is safer, but patient demands can drive care, and we're starting to look at how to manage that. So how do we balance what is best for the patient by traditional thinking or maybe new thinking? What is best and tolerable for the clinician? We have some concerns at Penn, and I know elsewhere, are we going to be able to manage the previous volume of patients, particularly after this post-pandemic surge that we're starting to see, with appropriate social distancing in the waiting room? And for many of us who have done telemedicine visits, frankly, they take more time and they're less efficient. One of our clinicians calculated that he would usually see 60 patients in a week and would be in clinic 2 days that week, and is now able to see about 30 to 40 patients, and he's in clinic 1 day and doing 2 days of telemedicine. So he's added a clinic day and still is not back up to his previous volumes. What are the payers going to be willing to pay for? Telemedicine visits, treatment at home, and so on. And frankly, we're all struggling financially. And what are the hospitals going to need to financially survive? If the payers pay for telemedicine visits with just a professional fee and not a facility fee, is that going to be a manageable type of thing? So there are lots of unanswered questions. But I wanted to just end by showing this article that myself and others published in JAMA Oncology earlier in the year. This was January, before the pandemic. And the concern in this article is that our oncology workforce is already quite strained, and that the number of patients is increasing faster than the number of providers, and that this is going to be a real problem for us. And my concern, and many of our concerns, is that the redesigned care that we're delivering is just going to exacerbate this problem. So with that, I'll end, and thank you very much.
Thank you, Dr. Shulman. That was a really great overview of how Penn Medicine responded to the needs of cancer patients during the pandemic. I especially found your slide regarding the time savings gained by patients who receive care at home to be really impactful. And I can attest as someone who lives in the Philadelphia suburbs that your time estimate is probably correct. So we are going to move into the Q&A session now. I'm going to ask Gina and MiKaela to join us back on video and go off of mute. There they are. Okay, great. All right, so going through some of these questions that came in. Start with this first one here. How did you decide what treatment regimens could safely be delivered in the home setting that used to be delivered in the infusion unit only? So this one will go to Dr. Shulman.
Sure. Thanks, Jessica. So we went slow. We started actually with Lupron, which we thought was pretty safe to give at home. The patients who were getting it were largely breast cancer and prostate cancer patients who had stable disease. Anybody who had unstable disease, we still had come into clinic because they needed to be more carefully assessed. But it turned out, and you saw the graph there were a huge number of patients who were really quite medically stable, and giving Lupron at home should be as safe as giving it in the clinic. But then we started to add, a patient who has rituximab and has received several doses, and we know will tolerate it without allergic reactions. It's actually pretty easy and safe to give at home. Same with some of the checkpoint inhibitors, where patients we know have tolerated it well. They haven't shown the rare toxicities that we see with the checkpoint inhibitors. Most patients do fine. A few patients have a lot of problems, but they've already declared themselves into the group that is doing well. And again, they have stable disease clinically, and we're able to tolerate it. So that was sort of how we started to think about things.
Great, thank you. So MiKaela and Gina, I'll ask you a similar question. How did you decide what could safely be delivered through your curbside clinic?
Well, as I said before, we already had we already had stood up the shot clinics and decided what could be given in those clinics. So we had a list that consisted of hormone injections, growth factors, some immunizations. So we went with that same list of drugs, but then we decided to add the chemotherapy. So added the Velcade, did a pilot for about a week to see how the patients would like that, made sure we have a lot. I didn't really focus on this, but I'll just say that every single safety check and every single checklist and pre-assessment that's required for administration of chemo per the ONS chemotherapy and immunotherapy guidelines. Everything is done consistently with those guidelines, and even though we're doing it at the curbside, there's no difference in safety. We have barcoding machines at the curbside, a computer with access to the EHR. We print the armband at the curbside, apply it to the patient using 2 patient identifiers. So we really didn't compromise any safety with doing this, and made sure that whatever drugs were safe to give at the curbside, we added those in. We do some on-the-body injectors and lots of other. There's probably a list of 10 or 12 drugs that we do at the curbside. For our chemotherapy, we actually have a scale that we bring right to the patient's car, and we weigh them. We do a set of vitals, and then the nurse completes the assessment. Even though the nurse the night prior also did an assessment, we do an in-person assessment before the chemo's given. So lots of safety checks in place.
Great. Okay, thank you.
Jessica, could I just add one thing very quickly? Because they've made me think of a few things. You may wonder who actually gave all those treatments at home, because we went from a few to a lot within a couple of weeks. And actually what we did, which is only a temporary fix, was redeploy our infusion room nurses because their volumes were down, and they were rapidly turned into home nurses and helped to deliver a lot of the care at home. And I will just mention that we had all the same safety checks, obviously, that MiKaela was talking about at the curbside. That went without saying. The patients were, going through all the same checks.
Great. Okay, thank you, Larry. MiKaela, going back to you kind of on the same topic, how are you ensuring infection control at the curbside clinic? Were you concerned about creating a sterile field?
We have rolling carts that we use. We have hand gel. We have cleaning solutions. We are very meticulous about wiping down the surfaces and all the equipment between every patient. We actually have kits for most of our vascular access care, which have saved money and improved efficiency. So we have a port access kit, a central line dressing change kit, a peripheral IV start kit. We have blood culture kits, which have sterile drapes in them, and so that we can easily create a makeshift sterile environment easily. I was a old Army nurse, and so it was easy for me to envision how to do this kind of stuff in more of a field environment. And I can say we don't compromise anything with infection or sterility. What we gain is not having the patient have to come into a nosocomial type situation where they could have a risk of infection themselves. So it's going pretty well.
Great. MiKaela, I did not know you were an Army nurse, but I could see how that really came in handy in the last few months.
Yep.
So I'll start with Dr. Shulman on this one. Are there any payer or billing regulations related to providing care in the home that cancer centers should be considering if they want to set this up?
So the answer is yes, and for me to go through all the nuances, we'd have to extend this another hour. There are a few considerations. First of all, the coverage specifics from the government payers, CMS, Medicare, and Medicaid are different than they are from the private payers. And there are a couple of aspects of that. First, the degree of coverage for the visit and the level of copay. And then there are also some special issues with the drug coverage, paying for the drug and how much out-of-pocket cost there is. And that also varies greatly by the payer. So that's one aspect. That's sort of, a little bit about what we get paid, a lot about concerns about whether it's tolerable financially for the patient. We are doing some pretty detailed financial analyses of how we would support an enlarged home care staff, because those infusion room nurses are going to have to go back to the infusion room, and how much revenue we lose and what the differential of infusion room revenue versus home revenue is. And in the meantime, we're arm wrestling with the payers, and I was on a call earlier today a little bit about this, to try to make sure that this would be a viable alternative for patients going forward and for the institution. It's a complicated thing, and it's still one of the unknowns.
Got it. Yep. So definitely not a straightforward process for that yet.
No.
Okay. So MiKaela and Gina, what about billing and payer issues related to the Curbside clinic?
Yeah, our clinics, when we ran them inside the building, they were in regulated space. Now, we're governed by the HSCRC in Maryland, so our rate structure and sort of how things are done are a little bit different, but we have to play by the same rules. We got the attorneys involved at the front end. I mean, part of this was even, can we do this? Who owns the curb and the space? And being in parking garages, was the garage that is not owned by the hospital, is the garage owner taking on liability by having these kind of things in the garage? All that stuff got settled with the attorneys. And we've had a couple of clear passes with the finance people that were okay to roll our practice sort of through a door and out onto a curb and still bill it as regulated space. Because with the regulated space billing, we get a facility fee, which is what brings in a little bit of money for what we're doing. It's like anything else, you're never recouping 100% of what it costs you to do it. But video visits there is still very up in the air, and that's something that's been going on for a while now. Pretty established way of documenting and all this kind of everything's been figured out, and yet you can't get anybody to give you a clear answer about whether that's going to be a billable service going forward. So our nurses are billing until they tell us to do otherwise.
Got it. Okay. So we did have a question come in, and I think this is regarding telehealth. So let me ask this one. Patients often express appreciation for the support of the whole team, including medical assistants who are in the room, office staff, etc. How have you been able to add that sense of team support to those who need it when you are providing care via telehealth?
I can start with that. And so one of the things that I feel different about from the provider point of view and reflects what you're asking is, I've worked as a team with my nurse practitioner. And we would go in and, we might see the patients separately or jointly for part of the visit, but we were a team and the patients knew we were a team, and they, as you say, knew the medical assistant, staff, personnel. And, in a lot of ways that doesn't exist in the same way. It does it sequentially. I'll tell the patient they need a follow-up CT scan, and the front desk scheduler, who they know, they used to see in person, calls them up and says, "Hi, Mrs. Jones, this is Roy. Dr. Shulman wanted me to book you a CT scan. So there's still some interaction there, but it is very, very different. I will say one other thing, though, at least in my small anecdotal experience, and that is I've got to meet a lot more of the patients' families, little kids and other family members who pop in and out of the telemedicine visits who they didn't generally bring to clinic with them. And that's been one of the fun things. I think the one thing I would say is if you do need to have a private conversation with the patient, that sometimes is a little bit of a struggle if they really want to be alone and, to discuss whatever it is you need to discuss. But pluses and minuses to everything in life.
Yeah, definitely. Thank you. Gina, MiKaela, do you have anything to add to that?
Yeah, I think that the notion I've heard a few stories about, meeting other people during the visit, and that has a special feel to it as well. We've had a lot of positive feedback from patients. I think initially people were a little gun shy, kind of what would it feel like, what would it look like. We're actually still very much in a no visitor mode at Hopkins, and specifically in the cancer centers, we still have no visitation except with rare exceptions. So we're even, encouraging patients and families to set up Zoom visits for the appointment. So the family member may be in the car on their laptop or it could be at home, and they can participate in the visit by Zooming in and connecting with the provider in the room, or FaceTime or phones or whatever. We've kind of been encouraging that even for in-person visits for family who can't be there with patients.
We do a lot of teaching that way.
And do teaching that way as well. But we're still in a serious no visitor mode right now.
Yeah. Okay.
Yes, we are. Yeah.
Yeah. All right. Let's move on to a little bit of a different topic here with this question. How do you think the large decrease in routine cancer screenings that we've seen across the nation will impact cancer care going forward? In regards to, is your center preparing for an increase in screening needs? Do you think that maybe there's going to be later stages with cancers? And let me throw in there also, what are your thoughts about continuing with regular screening right now? Is that something that patients should be doing? Dr. Shulman, do you want to start?
Yeah, sure. So what we've seen at Penn over the last 4 months is a substantial reduction in our new patient visits. And I'm sure that doesn't reflect the fact that fewer patients are getting cancer. It's just fewer patients are getting diagnosed. And eventually those patients are going to be diagnosed and will be coming in. And we've been trying to figure out how to manage that post-pandemic surge. And I'm not sure how we're going to do it, particularly with the issues I mentioned before about trying to keep our waiting rooms uncrowded, and so on and so forth. So we're talking about extended hours, more weekend hours, both in radiology and in the clinics. But I think it's going to be a challenge. Those patients are going to show up one day, and the concern, of course, is, as you suggest, when they finally get here, they're going to have more advanced disease. When I talk to my leukemia team, Keith Kratz, who MiKaela and Gina will know, because we stole him from Hopkins a while ago, he said the number of new leukemia patients they were seeing was down by 50%. Where are those patients?
Oh, wow.
Heart disease to hide from. So we're all trying to be prepared for that. I will say, as I mentioned before, patients who we think need to be screened, many of them are still declining to come in for screening.
Okay, thank you. MiKaela and Gina, do you have anything you would like to say about the screenings?
I absolutely think that we need to get screening going again, and we may need to provide more mobile screening or other sites for screening so patients don't have to come into large academic places, but it's got to be a focus.
Okay, great. Well, thank you very much for that. I think we did have a couple other questions come in, but I see we just hit past our time here. So I think you all made really excellent points for all the stakeholders in our healthcare industry to consider going forward as we went through that discussion. That is all the time that we have for today. If there are questions we did not get to, we will try to respond via email, so be on the lookout for that. And we would like to say a very special thanks again to our supporters for making this program possible and our speakers for sharing their expertise with us. This was our final session of the three-part series. If you missed any of the earlier webinars, you can view the recordings on nccn.org/COVID-19. Recording for this session will be posted by next week. Thank you again, and we look forward to seeing you at future NCCN programs. Thanks, everyone.
Thank you, everyone.